this is Dr. Crawford. Today we're going to talk about ductal carcinoma in situ, sometimes referred to as DCIS. This is part of a beginning series of discussions about breast cancer, and this is a huge topic, so I thought I'd break it down into manageable parts. So we're going to talk about the most basic type of breast cancer, ductal carcinoma in situ, and we're going to cover a number of questions in this area. And they are listed here. So, what is DCIS? We're going to start with that. Then we'll be talking about the symptoms, how it's diagnosed, how it's graded. Can it develop into invasive breast cancer? And I want to give credit to Breast Cancer Now research group from the UK. That is a charity organization that does tremendous research and is responsible for the content of this presentation. So the first question is, well, what is DCIS? And what it is cells within the breast that start to grow abnormally. So they begin to divide when they shouldn't, but it is limited only to the milk duct. So that's where the milk normally flows as it's being used in physiological breastfeeding. But sometimes there's an abnormality and the cells lining the duct begin to grow. But DCIS is very important because there's no invasion of the surrounding tissues. About 15 to 30% of all cancers in women are diagnosed as DCIS. And in very few cases, up to 10 to 20%, it may be found in both breasts. But importantly, if it is removed, it's curative in more than 95% of cases. So that's why it's important to get screened. So here we see a diagram of the early form of breast cancer. DCIS would form within these ducts. So you can see the lobules where the glandular milk is produced, the ducts that carry it out to the nipple, and this is the breastfeeding apparatus of the breast, which is made up of these lobules and ducts. And then, of course, there's fatty tissue and chest muscle that bring the whole tissue into shape. So we're just focusing about lesions that would form right within these ducts and would stay confined within these ducts. Now, these lesions can be very difficult to determine unless you go for a screening. And that's really a very important aspect of the work that is done by clinicians to determine whether or not a woman has what it may not be felt, may not be noticeable, but nevertheless, something like this might be happening where the lining of the duct, the opening, becomes filled with cells. And if it's not taken care of and removed, over time, it could start to spread beyond the duct and become an invasive breast cancer. So DCIS has a very good prognosis. It is highly treatable, and the only danger is ignoring it or not knowing it's there because you don't get screening. And then over time, it could evolve into something more serious. So sometimes clinicians will call this a pre-invasive tumor, non-invasive, in situ, or stage 0, meaning that it is totally confined and therefore doesn't resemble fully an invasive breast cancer. So breast cancer, DCIS, is considered to be a primary breast cancer. So it's an early stage breast cancer. And it hasn't spread beyond the breast. It hasn't gone to the lymph nodes under the arm, so it's not spreading throughout the body. So it's a non-invasive breast cancer, not yet developed the ability to spread either within the breast or to other parts of the body. So this is a very, very important diagnostic understanding, that it is very simple, very treatable, but if not treated, the cells may develop the ability to spread and ultimately become an invasive breast cancer. And that's something that we don't want to happen. What are the symptoms of DCIS? Usually it has no symptoms. very often the growth, the abnormal growth, is so small it can't be felt. So usually they're found during routine breast screening, either by physician, breast screening, mammography, and for women with very dense breasts, sometimes it will be revealed only by an ultrasound. So now in terms of the diagnosis, how do we diagnose it? So first of all, a breast exam. Could start with a self-exam or a medical examination of the breast by a clinician. Again, this may not show anything. A mammogram, which is a breast x-ray, may show that there is some kind of a growth within the duct itself. But sometimes that's not visible with a mammogram, and therefore it may be advisable, if the clinician tells you that you have dense breasts, to go for an ultrasound, which uses sound waves to produce the image. Now, if there is something that is found or identified by the mammogram or the ultrasound or both, then there may be further testing. So this would involve removing a bit of the tissue to see what's going on, to take a look at it, to look at its shape and size, and whether or not the cells appear to be abnormal. And this could involve what's called a core biopsy or a fine needle aspiration. There are various ways to remove little bits of tissue from the breast, depending upon the location of the tumor. So this diagnosis then would be based upon imaging first, and then going directly inside the breast in a very minimally invasive way in order to check out that abnormal piece of tissue and see what's going on. Now, the ultrasound can be very important for this, again, because particularly in the case of very small tumors, they may not resolve very well with the mammogram. So again, you have to consult with your clinician. And you're going to have a very simple screening with an ultrasound, non-invasive. Mammogram is non-invasive. It's an x-ray, maybe a bit uncomfortable, as the breast may need to be compressed in order to get a clear image. But these are very doable tests with minimal side effects. So what's going to be the outcome? Okay, so these are some of the ways in which the physician or the radiologist will begin to look at the breast tissue after it has been imaged. So an M1 designation would mean that the tissue is normal for mammography. A U1 for ultrasound 1 would be normal. So it may look, your breast may look entirely normal, which is wonderful. A second choice in terms of what might happen is that you get an M2. So there's some kind of a growth there, but it's not, there's no sign that it's malignant. It just seems to be some kind of a cyst-like benign growth. And a trained clinician can very often make that ascertainment. Now, in M3, there's a bit of abnormality, or perhaps not sure, probably benign, but, we're not really sure what's going on. So we'd either call that an M3 or a U3. Usually we would look at this a little bit closer. So the clinician will decide to do a biopsy, probably benign, but let's just double check this and make sure everything's okay. Now, other more serious results could be an M4. So in other words, the appearance of this tumor in the mammogram or in the ultrasound result looks something like what tumors usually look like. And there again, the experience of being able to discern the presence of the abnormal lesion and the size of it and how it's interacting with the surrounding tissues, it's all going to be important. And M5 or U5 would be an outright cancer that can be diagnosed even prior to the biopsy. But when we're talking about DCIS, we're talking about an M3 or an M4. So once again, you're going to have a further examination by removing the bit of breast tissue that contains the abnormality. And sometimes this is marked in various ways, but at any rate, a core biopsy will use a hollow needle to get a sample of breast tissue, also you can do a fine needle aspiration, which is a needle is inserted. So the tool may vary, but the outcome is pretty much the same, which is that you're going to be guided, assisted. The clinician will be guided to find the location, exactly where that lesion is, and going to target it and remove it, sometimes guided by ultrasound, sometimes by other types of marker devices to remove it and examine it further. So it's a very non-invasive event. So that will then result in a pathology report. So what would that look like? It's going to talk about the kind of breast cancer result, if it is a cancer, the size, the grade of the cancer. We'll be talking more about that later. And then sometimes there are other post-surgical assessments. In other words, was it all removed? Has it spread? This is a very, very important pathology examination post-testing. The other thing that will be done, even with the DCIS lesion, is to determine whether or not it's hormonally sensitive. And if it is, then particularly with estrogen receptor positive, in other words, the cells have the estrogen receptor, then there are therapies that can be used to called endocrine therapy that can help to block the estrogen-stimulated growth of the abnormal cells. Also, calcifications will be looked for. There's a certain micro calcification pattern that's consistent with tumor. So all of these will be examined by the clinician and then explained to the patient. So how do we treat this? If it's determined that DCIS is present, then we're going to want to remove it. So surgery is the first treatment for people with breast cancer of any type. In the case of DCIS, this is a lumpectomy. It is very minimally invasive and leaves very little scarring. In addition, often radiotherapy is prescribed. So in other words, controlled high-energy X-rays in order to sort of make completely sure that all those cells are gone. So it's often done in the case of DCIS post-surgically, just to give it that extra boost of treatment to make sure this is gone and not coming back. In addition, if the lesion was contain the estrogen receptor, hormone therapy may be prescribed. So these are the ways in which DCIS will be treated: with surgery, usually with radiotherapy, and if it's hormone receptor positive, you're going to have a hormone therapy as well. Now, the type of surgery that's done here is called breast conserving surgery, okay, meaning that the breast is going to be left intact. And this image shows if this was the position of the cancer in the breast, you're going to have a tiny little incision mark that will fade over time. And we often call this breast conserving surgery a lumpectomy. Okay, so it's a local excision to remove the breast cancer. A little bit of normal tissue surrounding it is taken out just to make sure that it's all removed and keep the breast intact, and very short healing process. And then usually this would be followed by radiotherapy for a certain period of time. So what about the radiotherapy? Radiotherapy uses high energy X-rays, and it's targeted to the breast or even the part of the breast where the tumor was located. So it's not going to affect the whole body. It's just going to affect that tissue. And the purpose of it is to destroy any cancer cells that may have been left in the breast. Probably not in the case of a DCIS, but again, caution and being very conservative in terms of let's take every possible measure to make sure this is gone. And sometimes it's called adjuvant radiotherapy. It's the obvious reason is to reduce the risk of the cancer coming back. And sometimes, with certain kinds of breast cancer, chemotherapy is needed as well, but this is virtually never required for a simple DCIS. So you may consider radiotherapy only to the area of the breast where the cancer was removed, sometimes the entire breast. It just depends on the individual case. So this is something that will be discussed with the patient. The clinician will take the entire case history, family history, all of this into account in making these types of decisions. And there have been some studies where people with a very low risk of cancer coming back for numerous reasons, the size of the tumor, the location, the family history, they may not need radiotherapy. But this is something that is not completely agreed upon at this point. There haven't been enough studies that conclusively show which group of individuals might not need the radiotherapy. So this is an ongoing clinical ongoing assessment, and this is a decision that would be made by the clinicians and the patient. Now, hormone therapy or endocrine therapy is given to patients who have estrogen receptor positive tumor. So some breast cancers use estrogen in the body to help them grow. So the idea here is if the estrogen receptor is upgraded, it's present on the tumor, then it may be very useful to block that receptor if it's going to support the growth of tumor cells. So it blocks the effect of estrogen. And there are different types of hormone therapy, and they're very commonly used in women who have estrogen receptor positive cancer. So it may be recommended after the breast conserving surgery for DCIS if the tumor is found to be estrogen receptor positive. So in that case, you will receive some type of hormone therapy. And there's quite a few drugs that are currently in use. And I have a list of them here. Tamoxifen has been used for many, many years, as well as aromatase inhibitors. And then more recently, we have some more global acting anti-estrogen drugs that also have an important place, especially Gacelarin and leucovorin or Prostep have a very important place in therapy. So if you are prescribed tamoxifen or an aromatase inhibitor or one of the newer drugs, Zoladex or Prostep, usually the therapy goes on for about 5 years, sometimes longer. Again, depending on how the patient is responding to the therapy, in some cases, depending on family history and other factors, it might be continued for up to 10 years if it continues to show a positive effect. So this will be very much a person-to-person decision in terms of the individual patient and in discussions with the clinician. So let's talk about some of these drugs. They'll be taken for a number of years. They do have side effects, generally in many ways mimicking the effects of menopause, and sometimes, maybe even exaggerating some of those symptoms because it's a more rapidly induced situation where hormonal status is drastically altered fairly rapidly. So these side effects can be treated, should be monitored, and may be uncomfortable, so they should be discussed with the clinician. So tamoxifen has been used for many years. It's used to treat breast cancer in both premenopausal women and postmenopausal women. So it's sort of a broad spectrum hormonal treatment, and even by men, some men who have ER-positive breast cancer. So the estrogen receptor positive cancers, their growth can be inhibited, and that's shown here in the cartoon. Here we have the estrogen receptor, and then when we add the tamoxifen, it blocks that receptor, So therefore, you can't trigger cell growth in the tumor. And that's really important. And it really was one of the groundbreaking improvements in the treatment of breast cancer for women whose cancers have this particular receptor. And it's seen in a significant number of breast cancers, but that's something that's checked on an individual basis. Now, the second type is the aromatase inhibitors, and there are several of these that are in common use. Letrozole or Femara is used to treat breast cancer in women who have already gone through a natural menopause. Okay, so that's for women who are slightly older, who are postmenopausal. And aromatase inhibitors work differently. They block the body from making estrogen in the first place. So whereas the tamoxifen blocks the receptor, and therefore the estrogen can't get into the cell and cause trouble in terms of causing abnormal cell growth. In the case of the aromatase inhibitor, what it does is it blocks the ability of the body to produce the estrogen in the first place. Okay, so it reduces the amount of estrogen. Arimidex and Aromacin, these are all aromatase inhibitors, and again, they're very commonly prescribed for women who are postmenopausal. And so it's a very effective blockade to synthesis in the breast and in the ovaries of estrogen. Now, there's another type of therapy is used to treat women in premenopausal. So these would be women who are still getting their period. They haven't had menopause, gone through menopause, and one of the more popular forms of this is Glycerin or Zoladex, and it comes as an implant that's given as an injection into the abdomen. And what it does is it shuts down the ovaries so that they don't make any estrogen. So it's a more indirect effect on the estrogen, targeting the ovaries. It's called ovarian suppression. It can be done in premenopausal women to shut down the ovaries during cancer treatment, and then they can be reactivated later when the treatment is complete if the woman wants to perhaps have children after the become pregnant after this treatment. So that's one of the uses for it. And again, the primary breast cancers such as DCIS, it can be given every 28 days, and it's just a slow release over the month period. And it's again, for certain cases, it can be very useful. This more indirect way of shutting down the ovaries. And this is something that the patient will discuss with the doctor, and the doctor will bring it up if it's appropriate. Prostep, or leuprolidine, I can't pronounce it. Prostep is what we're going to use. It is used to treat, again, also premenopausal women. Also, here we see the ovarian suppression. So that's how all of these work. They're a newer class of drug, and what they do is they block estrogen production by the ovaries, and therefore the estrogen doesn't circulate in the bloodstream, and it doesn't target the breast, so that the breast, the response of the breast in abnormal growth is prevented. So we have the anti-estrogens that work directly on the receptor, like tamoxifen. And then we have the ovarian suppression induced by Prostep and other drugs. And then we have also, there are a number of aromatase inhibitors that block the production of estrogen. All of these target estrogen in terms of preventing it from being produced or used by the body to accelerate the growth of breast cancer tissue that contains these estrogen receptors. So it's a very useful therapy. It's a long-term maintenance therapy to keep the breast from being activated by estrogen so that we don't see recurrence of DCIS. We don't see recurrence of any cancer. The goal is not to see the recurrence of any type of breast cancer that is ER positive. So I'm going to end here, and I hope you have found this informative. And in the next video, we're going to talk about estrogen receptor positive cancer that is invasive, that has gone beyond its original location where the tumor originally formed to spread throughout the breast and perhaps to other tissues, and see how that type of cancer is treated. Thank you for joining me today.